Any other questions?
My name is Terry Michael. I'm a freelance reporter covering HIV/AIDS. I'm a member of the Washington Gate community, have been for 37 years. Dr. Montaner, I have watched ARVs devastate the health of two close friends over the last 15 years. I want to ask you, if I went to my doctor in Washington, a gay doctor, by the way, and he said to me, Terry, I have these 3 or 4 antibiotics I want you to take for the rest of your life because it'll protect you if you ever run into syphilis or gonorrhea. Would that not be medical malpractice? And why is it not malpractice to take highly toxic chemotherapies and give them to HIV negatives for the rest of their life?
I have never advocated to give antiretroviral therapy to negatives for the rest of their life.
Do you advocate giving them for PrEP?
My personal position is that PrEP is a niche opportunity that is something that can be offered safely to individuals that are engaging in high-risk activities that they want to protect themselves from acquisition of HIV.
How is that different from giving them antibiotics to protect them from for Saturday night at the baths?
No. The clinical research has demonstrated conclusively that if you actually give these medications to people who are at risk, this is both safe and effective.
Do you think that the ARVs, the studies, by the way, have been 2 or 3 year clinical trials?
Yes.
They have not been real world situations where you have treated people for 10, 15 years with these drugs.
But let me state that most of us feel that actually the use of PrEP is a transient phenomenon. People's risk varies over time, and they may not be likely to be needing PrEP for the 15 years that you're referring to.
One last follow-up. These clinical trials have been done always on third world people. The trial on gay prostitutes in Peru, Uruguay, Brazil, South Africa, and Thailand. Let me finish, please. Let me finish, please. Okay. Never on white people in the West. Why are these clinical trials? Well, name some.
The IPREC study, we enrolled men in Boston and in San Francisco, many of whom were middle class, so you're completely
5 to 10% of the total people who were experimented on. You know that. You know the numbers. You're not telling the truth when you say these were Boston and San Francisco. You're just not telling the truth.
The demographics of the men were quite variable, so I just think you're not correct in what you're saying.
Okay, then why not on white people in the West, mostly, as opposed to 90% third world people?
It's a function of HIV incidence and where the virus is spreading most rapidly. If you're doing a prevention study to show a benefit for the prevention study, you have to have a population where there's a high incidence. But in reference to several of your comments, number one, highly toxic. We did not see high levels of toxicity in the study. It was a carefully controlled clinical trial.
2 or 3 years, not 15 years.
Of course, and we don't hope that people aren't taking PrEP for 15 years. But the point is, the fact is we have proof of concept. There are guidelines that suggest very careful monitoring, and I totally agree with Julio. It is a niche intervention. It is something that we want providers to be smart enough to know about so that if they have somebody who comes in with rectal gonorrhea, for example, San Francisco clinic has shown rectal gonorrhea in and of itself is highly predictive of HIV seroconversion. Do you want to just treat that rectal gonorrhea, give the person condoms and expect them not to get infected? Well, the data suggests that that person who has rectal gonorrhea has more than a 5% chance of becoming HIV infected in the next year. Now, if we can decrease that risk by more than 50%, and if they're adherent by more than 90%, that I think is worth considering.
A lot of this.
Any other questions?